Thanks so much, Euron and Fiona and everyone. It's an honor to spend this time with you. Always a special honor to get to speak, and wish you well between now and our reassembly in Gothenburg. This is an amazing, amazing annual celebration of energy and learning. What a joy it is to be with you. But I find myself a bit of two minds, and maybe you do as well. On the one hand, you can't possibly be here as we've been for the past couple of days and not feel inspired and excited and hopeful. You scan the posters and the projects and the presentations. It's just one piece of good news after another. It's amazing. You really can see here how much improvement is possible. Absolutely. But underneath that glow is a different sense, I feel. It's a discomfort that everything isn't really well. Here's what I'm thinking. Maybe you are too. If this good work is in hand, if we've learned so much about how to make things better, why is the progress incomplete? Why does it feel like we are an island in a continent that isn't sharing the joy that we feel in these days? If we know what to do, why aren't we doing it everywhere now? There isn't any simple answer to that question, at least I don't know an answer to that question, but I have a hypothesis that I want to talk about a big cause. It's one I want to address with you and suggest that we should be thinking hard about how to change this. Now, to do this, I'm going to apologize right at the start, because I'm going to go back over some very familiar territory for many of you, maybe most of you. I'm going to be giving a talk that's going to feel to you like old hat. I want to go back to basics. I want to go back to the root theories, the DNA of IHI and the improvement movement, because my premise is simple. I think that if we are going to improve faster, more thoroughly, we've got to reaffirm the basics. We've got to act on them at scale. For almost 30 years now, I have held to the belief that modern quality methods can help. They can help a lot. But they can't help if we don't use them. This movement that we're in, this quality movement, it has a basis, it has roots in a theory of action. And if we understand that theory, if we support it, if we act on it, we can get further faster. You're showing that by your work here. But that's not easy. It isn't easy because we don't just need to honor the scientific underpinnings of our field. We've got to avoid something. We've got to abandon something. And that is other approaches that I think are slowing improvement. I believe that we remain victims of myths that poison our progress. And these myths have got to be disavowed somehow, and that's a big ask. They're intellectually impoverished theories that, despite the weakness of the theory, they remain very powerful. In fact, I think in many places, maybe most places, the myths are in charge. And that is what's stalling us. So I want you to come with me. Come with me on a bit of a journey, maybe to the past, a journey to the theory, because I want to unmask the myths with you. I apologize how I'm going to do this, though, because I'm going to do that first, as I did last year, by talking about my grandchildren. This is an addiction. It's a disease. If you are not so afflicted yet, you will be when and if you have grandchildren. I actually think that's okay, because I have believed for a while that everything important about improvement we can learn from children. So let me reintroduce you to Nathaniel, for starters. Nathaniel is my 5-year-old grandson. You're seeing him here sitting in one of his favorite spots in the whole world. He's sitting on a heating register, a vent in my home, and he's playing with Legos, the little construction blocks. Nathaniel will sit there for hours on end. He's in his own world. What he does, he makes Lego things. He'll make a spaceship, and then he'll take it apart. And then he'll make a bigger spaceship. And then he'll take that one apart. And he'll do it again and again and again, ever bigger, ever more complex ever more beautiful in his own mind. It's achievement, achievement, achievement. Why? I have to be fair to one of my other grandchildren. This is Caleb. I talked about Caleb last year at the forum. You may remember. He's now a year older. He's 3. And here he is in our den, in our house. What Caleb's doing is trying to bounce a balloon off the ceiling of the den. It's a video. Watch the video for a second, please. What are you trying to do? Why? Oh. I'll translate from Caleb. I said, what are you doing? He said, I'm trying to bounce a balloon off the ceiling, trying to hit the ceiling. I said, why? He said, because I need to. I think that's the title of my talk. Why does he do that? Why is Nathaniel making spaceships and taking apart? Well, you absolutely know why. It's an easy question. They're doing it for the joy of it. The joy of building, the joy of creating, the joy of improving. Nathaniel's 5 years old. Caleb is 3 years old. You could not stop them from improving. I'm a little embarrassed, but I was thinking about this, and I have memories of this myself as a child. When I was maybe 7 or 8 years old, my parents gave me an erector set. That's a box full of hundreds of little beams and nuts and screws and bolts. And you can build lots of structures with an erector set. But the biggest and hardest structure in the whole manual was a parachute jump. It was as tall as I was. It took me 3 weeks to build the parachute jump, I think. And then one day, I remember throwing the switch on the little tiny motor and watching these tiny little doll jumpers get carried up to the top of the parachute jump and then get released, falling down as their parachutes filled with air. I have had the pleasure of a lot of successes in my life, my work, and my family, but I cannot remember a bigger surge of pride and joy than I had at that moment. Keep us in mind, Nathaniel, Caleb, 8-year-old me. I want them to be our instructors. I want to show you a little counterexample. I'm not sure this will make the point, but I have the slide. I was in an airplane last year, and I went into the bathroom, the loo. And I noticed that on the counter, you see my photo there, is a bag. That bag is of coffee. It's a filter bag of coffee that they use to make coffee in the bathroom. And I couldn't figure out what was there. Then it suddenly dawned on me. It smelled better. The room smelled of coffee instead of the alternative. So when I was finished, I went out to the workstation where the flight attendant was, and I said to the flight attendant, that's interesting, you have coffee in the loo. Yes, we do. And it smells better because of it. Yes, I know. That's why we do it. I said, do you all do it? I said, oh, yeah. She said, the flight attendants all talk to each other to teach each other to do this. And I said, well, did you learn that in your orientation as a flight attendant? And what she said to me was, no. They tell us not to do it. Keep that in mind. The world is shrinking. Nation by nation, people by people, we're converging on quests in common, a lot of them in the pursuit of health and healthcare, as you can see here. It's a new set of intentions, new awareness. We're concerned together about the aging of populations because we're having success in taming infectious disease and child mortality. Chronic illness is the burden that comes with it. Singapore calls it the silver tsunami. Within the next 5 years, there are going to be more people in China over the age of 65 than there are people in the United States. We're together concerned about the costs of care. You know that. The problem is, of course, worst in my country, where costs are 18% of the economy. But even nations like the ones in this room, who are hovering at 9 or 10 or 11% of their gross domestic product, they realize that with all good intention, healthcare is confiscating resources. It's confiscating opportunities from other sectors, public and private. In my own state, in Massachusetts, Our government's budget in the state in the past 14 years has gone down for everything. It's down 30% for higher education, 25% for parks and recreation. It's down 40% for local aid. There's only one line item that's gone up in 14 years in my state, and that is healthcare. It's up 61%. That's confiscation. Nation after nation is setting goals to try to turn that around. England's trying to reduce NHS expenditures, the last I looked, by about 22 billion pounds. A massive goal over the next 5 years. And that's not because healthcare isn't important, it is. It's because other things are important also. We are united as nations in our concern about how to create health, the theme of this forum. Maureen described it so eloquently on Tuesday. Science shows unequivocally that healthcare is a weak tool. It's nearly impotent if we want vitality in populations. The biggest cause of ill health isn't the absence of health care, it's the presence of poverty and inactivity and poor nutrition, injustice. So nation after nation, we're shifting attention to causes, real causes, not just their effects. We're together concerned about safety, the worldwide patient safety movement, and I will credit Sir Liam Donaldson largely for his leadership here. People all over the world now know about the patient safety issue, and they're working hard on it, as you've shown in your presentations here. Nation after nation is interested in increasing consumer voice in one way or another, exploring what the real meaning of patient-centered or person-centered care is. I was in Denmark yesterday. I was there for a national meeting which is advancing a new plan in Denmark. It's called citizen-centered care. Person-centered care may well be the key rubric for redesign of Danish healthcare. And in China, person-centered care now looks like it may become the central rubric for the next 5-year plan for the Chinese healthcare system. We're concerned today together about how to make it all visible, transparency, measurement. What should we measure? For whom? What? And we're all, of course, fascinated by the shift to the digital age. So we see national projects underway to make this real. England has the new vision, the 5-year forward view, which you've heard about at this meeting. For a national health service that's radically redesigned and oriented largely around prevention and public health. The Scottish National Health Service is leading the nation with its early years collaborative, its integration of social services, trying to make Scotland the best place in the world to grow up. The Gulbenkian Foundation in Portugal has completed a sweeping report on envisioning Portugal's healthcare system for the future. Denmark, where I was yesterday, said has an entire national effort that may be mobilized now on what they're calling citizens' healthcare system, and the 5-page specification for that is worth your finding and reading. Singapore has a new agency that's focused on chronic disease management, the Silver Tsunami. And as I said, China's 5-year plan, the next 5-year plan, is still on the drawing boards, but I think it's going to be thrilling if it refocuses, as it promises to, on chronic care, primary care strengthening, and person-centered care. These are new aims. They're bold reconsiderations about what healthcare is trying to achieve. And they all center on the TripleAim, the brilliant contribution of John Whittington and Tom Nolan. They were the inventors. In 2006 at IHI, they pulled together this image of the social need for healthcare. You're all familiar with it now. Better care, better health, and lower cost. And it's come to unite us, or it could unite us. It's everywhere. It's a global language. In the English NHS 5-year plan, this is what it looks like in text, in the documents that lay out a series of goals and agendas for the 5-year plan, but you could sort everything you see here in terms of the TripleAim. It's a set of goals around better care, a much healthier population, and sensible, hopefully sensible cost control. So the goals are in hand. We've got an international vocabulary now about the direction of travel, where we want to go. But we're running into a problem. The problem is that we have the wrong systems to reach it, that the current design is not fit for purpose. The futurist Leland Kaiser has said it more or less, we have tanks, and we're trying to make them fly instead of building airplanes. I believe last year, the year before, I showed you the next slide. If you've seen it before, be patient with me. This is a bridge in the country of Honduras crossing a river, the Choluteca River. It was built in 1938, very strong, very well-designed bridge. The best bridge company in the world built it. The Hondurans wanted a strong bridge because the weather's terrible in Honduras, and the bridges get tested. Indeed, in 1995, this bridge saw its worst test in Hurricane Mitch, which hit Honduras, Tegucigalpa, head on. It killed people. It destroyed 150 bridges, I'm told, but it didn't destroy the Choluteca River Bridge. It stood. It stood strong. Just one problem. The river moved. So today, we have a strong and durable bridge in the wrong place. This is healthcare. This is sort of healthcare. The first bridge, under which a river still flows, that's the technocratic bridge, the audacious, hospital-based, acute care-oriented, curative bridge. It's the bridge that cures leukemia today, that fixes infant hearts with hypoplastic left heart syndrome. It's the bridge that gives you the best possible shot at beating your cancer. But there's a new river. And we in every nation are struggling to find a bridge across that river, and we're realizing more and more that the one we have, it can't do the job. It can't meet the needs of aging and chronic illness. It can't meet the needs of lower cost. It can't produce authentic prevention. It can't produce safe patient-centered care even. And it can't use all the potential benefits of profound technological innovation. We need a new bridge. We needn't abandon the old one. We need all that promise of excellence, but there's a new need, and we need new mechanisms. So the aims are getting translated into policy. Policymakers and leaders in nations all over the world, they're trying to build a new bridge with the wrong tools. The tools they're used to are payment changes, new incentives, enforcement of standards, trying to supply measurements that can help make markets work. It isn't going particularly well yet. We do not yet have, on a global scale, the pace and the completeness of TripleAim progress that our nations need. That's the problem. Why not? Well, I already told you my hypothesis. I think we need to take a closer look at the theory of action, how we're doing it, as practiced by nearly every successful company in the global competitive marketplace. It's the theory that unites us together. But unfortunately, opening the modern quality toolbox isn't what most of our systems are doing at scale. That's the wall we're hitting. They're not being modern. What they're doing is turning to slow and impoverished and scientifically unfounded methods that have achieved widespread embrace over the past decades or even century. The methods have a name, and this will be the old hat to you. It's called reliance on inspection for improvement. And let me walk you through for one more time how it works. Here's how reliance on inspection works. You want quality, so you define it, then you measure it, then you draw the distribution of performance, and you act on the outliers. You act on the deficient few. You decide that you want safe hospitals, so you measure patient safety, you go looking for unsafe hospitals, and then you close them, or you censure them, or you punish them, or you correct them. You decide you want patient-centered care, so you measure it, you find the few that aren't patient-centered, and you go fix that, or you fire them. I will tell you what 100 years of progress in the pursuit of quality affirms. Reliance on inspection does not work. Inspection does not achieve continual, pervasive, never-ending improvement. It doesn't build the new bridge. It doesn't foster creativity or learning or pride. It poisons them. Because the main harvest of inspection isn't learning, it's fear. This is the, I hope to you, famous cycle of fear described by Bill Schirkenbach at General Motors in the mid-century, 50 years ago. The day I start punishing Nathaniel for a spaceship that isn't good enough is the day he will stop trying to make spaceships better. No one graded me on my parachute jump. The cycle of fear produces anger at the messenger, manipulation of data by the frightened workforce, and tampering and nonsense in the internal management system that tries to protect the organization against the inspection. Now, let me be really clear. Finding problems, fixing them, is part of the total package of working on quality. Dr. Joseph Juran, brilliant leader, he placed that function, he called it quality control, in the framework of what he called the German Trilogy, the trilogy. The German Trilogy has 3 different processes. Altogether, they energize excellence. They include quality control, quality improvement, and quality planning or invention. You need all 3. here's how they act on a population. You use control to handle the very few who are outside the system on the low side. And by the way, a lot of that can happen right at the front line, not in a central office or inspectorate. You use improvement for most of us, for the vast majority whose main possibilities lie in continual learning, step-by-step improvement. And you use invention for a few, the few who have the time and the talent and the will to think through designs from the very beginning, to reinvent the world. The three of these need to be in balance, and therein lies the rub. We are way out of balance in our collective pursuit of better. Here at this forum, you know that there's a better way than over-relying on inspection and control alone. The way is scientific, it's grounded in theory, it's proven in practice, it's ready for use, it's continual improvement, it's what we celebrate in the forum. Learning in the face of complexity, that's why you're here. But here, you can see the product of that. You can see the vast improvement, the exciting invention. They're in the corridors of the meeting, they're in the posters, they're in the sessions, they're over coffee. You have met colleagues here who are achieving thrilling new results. We are a community of pioneers, a community of learners. We're exploring uncharted territory for each of us together, and we report back what we find. Examples, Dr. Arora, Sanjeev Arora was here yesterday. He's the mastermind of the ECHO project, this simple telehealth connection that can guide rural primary care clinicians all over this vast state of New Mexico to achieve locally eradication of hepatitis C virus at the same rate or better rate than if the patients had gotten into the tertiary medical center. He's moving knowledge, not people. ECHO produces better care at lower cost. It's a TripleAim result. You can meet Gary Kaplan, the chair of the IHI board, in his work at Virginia Mason Medical Center, one of the leaders in the world now who's working on lean production, the Toyota production system, reducing waste in all its forms, better care, better health, lower cost, TripleAim. You can find innovations in workforce design and other innovations in technology. I want to mention to you the PEEK system, P-E-E-K. It was invented right here in London, I think at St. Mary's Hospital, by two young ophthalmologists that I met just 6 months ago. They employ cell phone technology for eye care, including retinal exams, with the same fidelity as retinal exams at St. Mary's Hospital itself in remote African villages. Using PEEK, they've equipped teachers in schools in Kenya to do visual acuity screening, and they've screened over 10,000 kids in Kenya using cell phone technology, not moving people, moving knowledge. You can learn about breakthroughs in cell phone technology and text messaging in disadvantaged populations if you look at the program called Care Message. Care Message is the enterprise started by Dr. Vineet Singhal, a young doctor in California. He's demonstrated impressive achievements in self-care and chronic illness diagnosis. What he knows is the data show that SMS messaging is one of the only technologies known that's inversely distributed with wealth and income. The lower one's income, the more text messaging used. Dr. Singhal used this to develop a system of support, cell phone-based, to coach people with chronic illness in some of the most impoverished communities in cities around the United States, and this will expand. Hundreds of healthcare systems around the world are using this kind of innovation, design, and improvement methods to make things better. One example I must share with you is from a developing country. With the support of the Bill and Melinda Gates Foundation, IHI, as you may know, has been working now for over 5 years in Ghana with the Ghanaian leadership to help reduce under 5 mortality in that country. This is a learning system. Beginning in the very poorest provinces in the northern part of Ghana, in partnership with the National Catholic Health Services. Local clinics, district hospitals collaborated in testing new approaches to reliability in care, team-based care, patient transport systems, much more. What they learned, they taught. They then spread to their neighboring sectors. Eventually, it took 5 waves. The learning has spread to the entire nation of Ghana. The results so far look stunning. The last I saw, over a 30% reduction in child mortality in the northern sectors where it began in less than 3 years, 23% reduction nationwide. This was not done through inspection. It was not done through command and control rules or top-down incentives or markets. It was done by governmental and private sector investments in learning, exploration, sharing, collaboration, building the wisdom, building on the wisdom and the commitment of the front line. It's improvement for real. I'm honored today to say that Director General of Health from Ghana, Ebenezer Apia Denshira, and George Ajay, who has helped lead this project with the National Catholic Health Services, are with us. And Dr., please stand up and take our applause. That's a nation doing it right. You can meet others that want to do this. Get to know or join IHI's new Leadership Alliance. It's an organization now, 40 organizations strong, that are of hospitals and organizations that are pledging themselves to TripleAim results using thoroughly new, radical redesign principles. And that's the word I want to explore with you for a minute. It's the word redesign. If you're going to build a new bridge, you've got to have a blueprint. Redesign principles are the core notion from which we can devolve local, specific, doable changes. I want to explain what a design principle is. It's a little wonky, but stick with me, because it's part of the picture for I hope, the future and how it works. The way I did this is I made up a principle. I was watching Caleb with his balloon, and it came to me that normal people like Caleb, they like to invent, they like to play games. Caleb's game was make the balloon hit the ceiling. So I thought of a design principle to maximize that energy. The design principle I chose, I call make it a game. And lo and behold, a lot of smart entrepreneurs got there ahead of me. They're gaining customer loyalty. They're shaping behaviors by creating games. They're putting them into the world, even stupid games. I can't resist showing you three. One is Waze. You know, the traffic, there's an app called Waze, which will allow you to find your way through traffic efficiently. Well, I use Waze on my car. This is a screenshot of what Waze sends me every now and then. What you can't see there is on the left, my score as a Wazer. I've now used Waze enough, giving them information about where my car is, that I'm called a Wazer warrior, or a warrior Wazer. I have no idea what that means. But you should be one too. A TripAdvisor. I went on a trip with my wife and joined TripAdvisor to give them feedback on restaurants and hotels I stayed at. And here's again TripAdvisor coming back to me with more than information about hotels. They're scoring me. They tell me in only 7 days, my review has had 22 readers, and I'm only 3 reviews away from my senior reviewer badge. You're laughing because you want one too, I know. Here's another one that may be inappropriate. This has to do with hitting a target. I found this traveling just a few weeks ago in Patagonia. This is a Patagonian target. The next slide will give you a hint of where that target is, and the final slide will tell you exactly where that target is. Design rules like this make it a game. They're very powerful. They don't tell you exactly what to do. You'll figure that out. You're going to build your parachute jump. You're going to make your balloon hit the ceiling. But they're the general principles that help us unleash the creativity everywhere thematically. So I want to take another detour and show you the thematic rules, the design principles for the Leadership Alliance that I mentioned. There are a number of them. Let me go through them quickly. I know Maureen showed them to you in her talk. Rule 1, change the balance of power. This is the moment for what matters to you, medicine. This means that the control of the agenda, the priorities, they're going to shift. They're going to shift if we do it right, from clinicians to the people they try to help. Second, standardize what makes sense. We have vast experience with the Toyota production system in healthcare. Standardization, smart standardization of the things that ought to be standardized, it creates smoother processes. It makes it simpler for everyone. But the third rule is make it more complex. While you standardize what makes sense, customize to the individual. Standardizing what makes sense makes space and resources available to customize what needs to be customized. The brilliant, brilliant words of Taiichi Ohno, the inventor of the Toyota production process, came to me here. Ohno said something that's a little zen, but it's really good, I think. He said, when waste is at a minimum, every customer can be seen as an individual. Have a beer and think about that. The reduction of waste and the customization of our work are linked. The next principle is the most important of all. It's collaboration and cooperation. This new care is going to place on the pedestal of professional duty the duty to cooperate. It will rise above the prerogatives of professions in importance. The next is eliminate walls. That's what this forum's really been about. We can't achieve health with healthcare. So the new care is going to have to reach far outside the walls of current institutions to focus on well-being and thriving, not just cure, and that's what you've been hearing about session after session the past few days. The next theme is assume abundance, not scarcity. We have enough. Return the money. We are not entitled in healthcare to disable other worthy public and private missions by seizing resources that we do not need. We've got to return the money. The next principle is my favorite: make it easy. Healthcare does not have the right to ask people, patients, families, workers, to cope with rules that do not make sense, to engage in endless rework, to confront insulting complexity. The next rule is move knowledge, not people. The visit or hospital admission, I think, is going to come to be seen universally, I hope, as care of last resort, not first resort. Create well-being is the next principle. This is the big idea of moving us toward what Dr. Wayne Jonas calls salutogenesis, recognizing the production of health is not the combat of illness. It's a different and worthy and important enterprise of its own. And finally, the theme you've heard again over and over from speakers on this platform: create joy in work. Remember Nathaniel. We need his energy. Through this lens, then, you see Peak or Echo or the care message system. They're not just good ideas. They are good ideas. But they're instances of the use in the world of a principle: move knowledge, not people. That principle is pregnant with thousands of yet unborn, doable changes if we trust ourselves to search for those changes and help others find them. So the job, to me, I began to think of as assuring the principled reinvention of healthcare, the new bridge founded on new core ideas of design, wherever those take us. Do it with inspection, do it with punishment, do it with blame, do it with fear, do it by finding the miscreant few and correcting them or firing them. No, that can never work. It has to be done through continual improvement and the theory and method of that. The pioneers of that new way, like our Ghanaian friends, they accomplish what they do with management and leadership approaches that are modern. They support the theory, the powerful combination of cultural changes, technical changes, strategic leadership changes. These are, again, basics. They foster a new culture, a culture that values information. It values especially information on defect. They cease blame. They trust their workforce. They invite their workforce, all the Nathaniels, all the Calebs, to use their imaginations, their creativity, their teamwork to reinvent their care, to build their next spaceship. Are the workers going to get it right every time? Of course not. Nathaniel doesn't. Caleb fell down. When we take a powerfully new design principle and try to make it work in real models, it takes time, it takes risks, and the right culture says to the pioneers, try. Even if you fail, try. Because in every single failure lies the seeds of the next success, the lessons you can learn and share and celebrate, and give voice to the families and patients and people, the carers in the community. The people who we serve know more about what the needs are, what goes wrong, what can go right than we do. The best teachers are the people who we serve. Technique matters. Learners adopt as policy systemic approaches to studying and improving processes. You know the model that IHI has used and brought forward, contributed by associates in process improvement: set an aim, develop metrics that tell you if you're getting there. Caleb watches where the balloon goes. Nathaniel studies his spaceships. And then find something worth testing, a good idea from the next poster you see, and then put it to work with PDSA and sing as you do it, as the Scots do. This is the democratization of science. It is the spread of inquiry and learning through an entire workforce. And with culture and technique proper, the improvements are highly strategic in the right hands. Leadership invests in them. Nothing happens at scale in the journey of improvement unless and until leaders, boards, executives, ministers, respected physicians and nurses, government officials, it's leaders, only leaders, who can set in place the atmosphere of inquiry and mission and pride and joy that gives thousands and thousands of Nathaniels and Calebs out there the time and the security and the training and the acknowledgement to set about building their spaceships, trying to make their balloons soar, and then telling each other about it, sharing what they learn. We need our TripleAim, but it is going to be out of reach until our organizations and our governments and their stewards openly embrace it. If we want a better, healthier world, we need the new bridge. If we want to recover the lost time and energy and tempo that we're wasting in silos of fear and withholding, then leaders and teachers in the healthcare enterprise in the world have to come to terms with something basic and very noble in human nature. And that is that just like Nathaniel, just like Caleb, we were, every one of us, born to learn. And that learning is the greatest resource that humankind has for rescuing itself, not just in healthcare. But there we have the problem. Too much of the world remains in thrall to a theory of action that poisons that resource. It's a theory based on myths. They're toxic myths. In essence, this theory births a set of design rules that cannot gain us the change that we need. It's the wrong rules. It's the theory that if you want winners, you have to have losers. It's a theory that sharing and growing together is naive, and that competition holds the key. It's the theory that markets, even predatory markets, build the best bridges. It's the theory that the human nature to rely on for progress is not the native capacity to learn, but the primitive pursuit of blind self-interest. It's the theory that out of perfect, self-interested pieces will somehow emerge the cooperative, self-aware, inclusive community of effort in which we will thrive, the exact community you have felt here for the past 3 days. As I told you at the start, the commitment to basics is both affirmative. I really think we need to learn and practice the modern scientific approaches to improvement, but it's also negative. It's to reveal and abandon myths that prevent improvement at the scale we need. Do not believe the myths. Let me show you the myths. These are derivative of reliance on inspection. The first myth, incentives will save us. They will not. We're going to have to deepen our trust in intrinsic motivation. The second myth is that skin in the game will save us. If patients and people pay more, they'll do better. It won't. Patient power, person power, the voices of patients and families, they're essential to help us reorient the effort to, in Maureen's words, what matters to you. But the people we serve have plenty of skin in the game now. There is simply no scientific evidence of merit that says that when people pay more for their health care, especially at the point of service, they make wiser choices or care improves. It does not. The only thing that happens is that people of lowest wealth and income do worse. The third myth is that measurement will save us. It will not. The measurement that we need is just enough measuring, just good enough measuring. Instead, the deluge of metrics, which is flooding healthcare systems today, it adds massive costs. It distracts us from what really does matter. It tries a futile enterprise. That enterprise is to objectify the crucial subjective. And most assuredly, measurement cannot help us unless we get much better, not just at measuring variation, but interpreting it. The fourth myth is that accountability will save us. It will not. I'm an unbridled fan of transparency for all sorts of reasons, mainly because it supports learning. But relying on accountability as a driver of change and improvement, it is a close cousin to relying on extrinsic motivation. We have to handle accountability with enormous care. It would shut Nathaniel and Caleb down in a minute. The fifth myth is that standards will save us. No, smart standards count, but not when they compel compliance at the expense of continual learning, experimentation, and growth. The sixth myth is that markets will save us. I don't think so. Again, transparency, power to patients and families, they're important for progress. But the evidence is sparse, maybe none, that healthcare delivery improves in the normal way that supply and demand work for most products and services. In contrast, probably the most important resource in assuring better health and healthcare isn't market competition, it is cooperation, coordinated planned flow, which becomes more difficult in market-based thinking, in win-lose games of strategy. Markets in healthcare do accomplish one thing over and over again. They assure oversupply. They assure non-value-added care. They assure waste. The seventh myth is that technology will save us. Technology helps. I showed you examples when it makes flow smoother, when it reduces opacity, gives people more control over their own care, creates options. But technology can also just simply replicate a broken system and make the broken system work faster. Electronic medical records are a case in point now. Bob Wachter is here with his new book, The Digital Doctor. Read it and understand the hazards of relying on technology as if that were the answer. Myth 8, the biggest myth of all, it's that healthcare will save us. It can't. Maureen's eloquent opening session reminds us again that healthcare is a remarkably weak tool for achieving health. I don't believe these myths anymore. The heart of improvement isn't controlling, it's unleashing. You can see it here, right here in the forum, right now. We're here today, we're not here to blame or to exhort or to punish or reward. We are here to teach and learn and share with generosity and optimism. We're not here to confine, we're here to encourage. Of course, it isn't Legos we're building with. We're building with systems much more complex, much more nonlinear, much more interdependent. Nathaniel and Caleb they can smile alone. We can only smile together. That reminds me of one final story before I close. This story is more than 20 years old, but it's your direct ancestor. It's about a hospital far away from here in California. It was called Dominican Santa Cruz Hospital. I remember this well. It was in the early days of progress against complications in intensive care units. A breakthrough had occurred. It was due to the work of Carol Harridan and a few others at IHI, who devised what became known as the ventilator bundle. By a bundle, they meant a set of 5 care processes, simple processes, that, as it turned out, if adhered to with absolute faithfulness, could eliminate a dreaded complication for people on mechanical ventilation, respirators, ventilator-acquired pneumonia, VAP, pneumonia caused by the machine. We knew how to do it. Dominican Santa Cruz was led by a chief operating officer, not a physician, a guy named Lee Vanderpool, and they adopted the ventilator bundle in their ICU. They worked very hard, as the Ghanaians did, with local teams toward reliability. They tracked complications. They succeeded. They went 9 months, I remember, without a single case of ventilator pneumonia. And then one day, Lee Vanderpool phoned me. He said, "Don, I'm sorry to say, our run has ended. We had our first VAP in 9 months last week." I said, "I'm sorry to hear that, Lee. What did you do?" And I remember Lee's answer as clearly as if he had called me this morning. Lee said, "We all sat together in the ICU and we cried." That, my friends, is the answer. They cried. They didn't cry because of incentives or markets or rewards or punishment or fear or exhortation or requirement. Those tears, they came from their hearts. They came from the meaning in their work. They came from the connections among the people and with the people they serve. They cried for exactly the same reason that Nathaniel smiles at his next spaceship, that Caleb jumped with joy, and I saw it when his balloon finally hit the ceiling, because it matters from within, because I need to. Many of you in this room sit here together as pretty powerful people, executives, government officials, clinical leaders. Others of you hold custody of a vision for some people in a tough and very demanding world. I will tell you, that world is today inviting you to cynicism. The tools you'll notice in your hands first in that world are laws and regulations and compensation systems and budgets, dicta and fiat, measurement, standards, measurement. They are seductive. They make you think that you can mandate improvement, that you can command knowledge growth, that you can require excellence. They're deceiving you. You cannot. Of course, laws matter, regulations matter, compensation, budgets, policies, they all matter. Standards can help, measurement can help, control can help, but only in proper proportion and only if they don't harm. Only if they avoid waste in time and ideas and spirit, only if they maintain deep respect for how complex the real work is and how good at heart the real people are. 30 years in the vineyards of improvement have taught me how impoverished, how blunt, how inaccurate, yes, abusive, the tools of inspection and incentive are without deep understanding and respectful action regarding the nature, the sources of interdependent human achievement, the tears at Dominican, the pride in Ghana, the smile on Nathaniel's face. Caleb's aim for the ceiling because I need to. Leaders can do much to help this, to accelerate this, to nurture learning organizations in learning nations, and I hope someday a learning world. That, by the way, is what IHI is doing with the 100 Million Lives campaign, the Leadership Alliance. Study these, their invitations to you to join in this other way. They create space for learning. Leaders can do at least the following to nurture this. First, without any apology, declare the need for improvement on the dimensions of the TripleAim. Set aims, set bold aims, leaders, for patient safety, for reducing senseless variation in care, for shifting to patient-centered, person-centered care, for reducing the causes of illness like obesity and inactivity and poverty, environmental threats, injustice. Reduce cost. Aims matter. That's okay. Second, develop and continually improve, though, totally transparent system-level metrics of progress. We need measurements on those aims, including metrics of health status and cost, quality. Ghana couldn't reduce child mortality unless it tracked child mortality. Measures can help. But then, invite the voices of people, patients, carers, families, communities into every single part of the healthcare system. Improvement teams, governance bodies. Help you develop the designs, make the principles real everywhere. We need to give people the power to reshape the care upon which they depend. And then assure that the current and future healthcare workforce at all levels, in all roles, have the skills and knowledge that they need to be active participants in and leaders of change, and to cooperate among themselves and with patients, families, and communities in doing that. I don't know how many people in Ghana, in the healthcare world, became capable of improvement in the journey of success, but it's hundreds, maybe thousands. We need a new charter for the preparation of health professionals, and that preparation should include the ability to help improve care. And then work with the spirit. Work steadily to build pride and joy in the healthcare workforce, to build their health, their knowledge, their opportunities to help change and improve the work that adds meaning to their lives. Cease blame, cease accusation, reduce fear, substitute growth and learning. I think that nations committed to achieving the TripleAim should invest in learning networks of providers, fellowships like those wonderful Scottish singers you just heard. They count. They're supports for innovation in care delivery, superior substitutes by far for reliance on inspection. And then, of course, and maybe most of all, let's do this together. Learn together, not separately. Let's assure that this improvement movement becomes a majestic, a powerful engine of human learning and progress in a worldwide scale, that we stand up as a movement for the approaches that can work and reveal the poverty of reliance on inspection for what it is. I favor laws and regulations and compensation and budgets and dicta, everything there that celebrates this, that celebrates human growth, creates the circumstances, cultural, technical, strategic circumstances that call on the best and ever-present nature of people. We all began as children. We all sat up late building our spaceships, carving our creations. On some wooded trail, spotting some overhanging branch, and with no one else looking and no one else caring, every single one of us as children jumped as high as we could. We tried over and over again to touch that branch. What I hope for Nathaniel and for Caleb is that their spirit grows, that the joy they seek today as kids in achievement with toys becomes the joy and pride they seek in lives of service, in the company of others. I hope for them leaders who are wise enough and patient enough and generous enough to build for them the platforms, the organizations, communities, public and private agencies that can invite them to grow and learn and help. Thank you very much.